what can we monitor with these really cool things we call PA catheters? This is one type of PA catheter. It happens to be a Swan-Ganz catheter. It's a brand of catheter. What can we monitor with a catheter that sits directly in the pulmonary artery? All kinds of neat things, okay? And we're going to talk about each one of these things and what they mean to us as nurses. Most importantly, what are we going to do with that information? So when you're in intensive care, guys, you're going to have so much data that's available to you that you have not had before, okay? So you're going to see some things and some numbers, but a number is useless if you don't know what to do with it, right? It's just a number. It means nothing to me. If you don't know what your Ola gauge pressure should be, then it's just a number. It's like, okay, I guess that's good. I don't know. We got to know what to do with it, right? So one of the first things we're going to talk about is the setup of it. You will not be tested on the setup. Why? Because you may have an iPhone, what number is that?
13.
13, or you may have a 6. Boards isn't going to test you on equipment-specific things. They're going to test you on concepts related to invasive devices, but not the specific invasive device, right? Because everybody's a different one, okay? It depends on the brand and what equipment you have in your facility. What we need to know is what we're going to do with that information that thing gives me, okay? So I just want you to understand how we're getting these numbers. So we have this catheter that's inserted and goes into the pulmonary artery. So is this an invasive procedure, guys? It is. So knowing it's invasive, what are you already worried about? What are you thinking in the back of your brain? Infection. What else? It's in the vascular space. What else are we worried about? Bleeding, hematoma. Okay, we get that, okay? So see, that's what I'm saying. You don't need to memorize that. You already know that. But I want to show you how we get these numbers. Don't worry about this either. Just want to get you to understand some things. Every hemodynamic assessment in your intensive care will have a pressure bag with it in order to produce a waveform on the monitor and give me that number, okay? This is a pressure bag. They give me all kinds of toys. These are disposable now, which makes them good for me because I get the toys afterwards. So you'll see the little sleeve here in the pressure bag. It's got a little hook at the top. They'll put a bag of fluid in here. It can consist of 3 different options. Citrate, which I have not seen in a long time, straight up normal saline, and then a very dilute heparin premix. Now this heparin is not something we can use for an IV transfusion because it's way too dilute, infusion, not transfusion. It's only 1,000 units in 500 mils. That's not going to anticoagulate anybody. Okay, a standard heparin drip is 25,000 units in 500. So you can see a big difference there. But they'll put that fluid in here, and usually it's depending on what do we have available. That's what determines what we put here, okay? We hook it on the little hook, and then we take this pressure bag, we turn our little stopcock open, and we start to inflate the bag. Now there's a couple important things that we're going to note about the inflation of the bag that you do need to know. I.e., first one is that it's got to go to 300 millimeters of mercury. So that's an important thing to note. 300 millimeters of mercury. It has to be inflated to 300 millimeters of mercury. You're going to have different types of devices. This one happens to have a little dial on it. Some have a little pop out. It doesn't matter which one you have. It's got to go to 300. Okay? And we'll talk about why it needs to be at 300 in just a minute. Okay? We're going to have a waveform that's going to be produced on the monitor. This is going to be connected to a transducer, which gives us that number. Because what's happening is this. We're in an arterial space, right? Pulmonary artery. Or if it was an A-line. We're in an arterial space. If you were to put an IV inadvertently into, instead of an IV, it becomes an IA, what are you going to notice right away on your flashback? It's going to be pulsating, isn't it? Because it's in an arterial space. The purpose of this counter pressure is to prevent that backflow. That's one of the things it does. It takes 300 millimeters of mercury of counter pressure to keep that blood from backing up my tubing. Now, why is it standardized at 300? Because this little thing called a transducer, which I'm going to have in another picture, is what's taking that energy in that vascular space, knowing it's calibrated with 300 millimeters of counter pressure, and that's how it's giving me a number. So just like a scale, Do you want your scale to have 10 pounds on it already before you put your big toe on there?
No, ma'am.
Head to the nose. Okay? We want it calibrated so that I know that the weight I've got on there is legitimate. Ergo, that 300 millimeters of mercury. That needs to be consistent and maintained so that the number I'm seeing on my screen is indeed accurate. Because that little bitty transducer is taking that energy and converting that number for me. Okay? I'm going to show you the big picture here in just a few minutes when we get to the A-lines. So don't memorize this. I want you to understand it. You do need to know the type of fluid. You do need to understand 300 millimeters of mercury is very important. Again, you're not going to be tested on the different kind of ports. I just want you to understand how we're getting this information. What is this thing telling me? I've got a port on here that can give me a core temp. Y'all remember we talked about core temps the other day in SIM? I've got a PA distal catheter on here. I'm going to try to do something with my glasses on. That should be my yellow. Yeah. This catheter port here is going to give me my pulmonary artery pressure directly, okay? And then I've got some other ports that will measure other things throughout the, there's different holes, if you will, little sensors along here that tell me that are measuring in different points along the way, okay? And it'll make more sense in just a few minutes. I'm not even going to talk about this right here. I'll explain it to you later. In my day, we would wedge balloons. So when we get to wedging balloons, I'll talk to you about what that means. You do need to know what the number tells you, but you do need to know also you're not going to be allowed to wedge balloons anymore, okay? So we'll hold that thought and we'll revisit it in a moment. So here's the big picture of everything, what it looks like together. Here's the pressure bag. This one has to have a dial, and you can always see the green really quickly. What's in the green? What number? 300. If it were like a turkey baster has a little pop-out thing, it would be a little pop-out at the bottom that has a little ring that says 300. It's green, okay? It doesn't matter. They're just different models. Here is a transducer, right here, right there. Those are the little tiny things that are taking that energy within that vascular space with that 300 millimeters of counter pressure and converting it to a number for my display on the screen. So what's going to happen is on my screen I'm going to have a waveform and an accompanying number. My responsibilities are to make sure that pressure bag remains at 300, to make sure I have an appropriate waveform displayed on my monitor, and then we're going to talk about zeroing and calibrating it. How do I know that that number is legit? Okay? This is kind of putting it, all the different pieces of equipment together. If you're about to have a patient undergo an invasive procedure, what do you have to have? You have to have a consent. So don't memorize for a PA catheter you need X, Y, Z. You have an invasive procedure. What do you need to have? Okay? Consent. It's in the vascular space. What values might I have looked at before we did this procedure? CBC, PT, INR, those are the biggies. If this patient's INR is way out, we don't need a PA catheter today. We got to figure something else out. Or it's my responsibility to communicate that, isn't it? Okay. I know that the site, the insertion is going to be sterile, correct? I know it's going to have a sterile occlusive dressing over it, correct? See, nobody had to tell me that because I already know what an invasive procedure entails. Okay, that's why I don't want you memorizing anything. I want you learning and thinking and applying. So we're responsible for making sure the equipment's ready, consent's done, any important labs have already been communicated, okay, and that my patient understands what the physician has told them. Do I explain the procedure to the patient? No. So this is important. We already talked about my responsibilities are to maintain, clearly a sterile environment, even after insertion, right? Sterile dressing change. To maintain the bag at how many millimeters of mercury? I need to make sure that I have what on my monitor? Corresponding appropriate waveform. We're going to talk about the differences in waveforms. And now this is my third and big responsibility, that it has been zeroed and calibrated at the phlebostatic axis. So where's the phlebostatic axis? Well, it tells you right here. Fourth intercostal space, midline. You guys, when you were in fundamentals and you learned how to take blood pressures, how was the arm supposed to be positioned in relationship to the heart? Level, right? We're measuring pressures within the heart, so we need our equipment level with the heart. Just like when you were in fundamentals, if your patient had their arm up too high, what happened to your blood pressure value? It would be falsely low. If your patient's arm was below the heart and you checked it, what would happen to your number? Falsely high. If you use the inappropriate sized cuff, wouldn't that give you an erroneous number? Okay, these things matter. So when it comes to zeroing and calibrating your equipment, I'm not going to teach you how to zero and calibrate because every monitor is different. But I am going to teach you where it needs to be leveled with. Do y'all remember in sim orientation there was a yardstick hanging on that pole, had a leveler on it? Well, I went and bought my materials at Lowe's and made my own, dang it. They have them, you will see a yardstick with a built-in leveler in the intensive care. It's as fancy as that equipment gets. That's what we really do use. But since I was buying out of my own pocket, I bought the cheap way around. Hot glue it. We're going to take that transducer that we just looked at, the transducer holder, right here. There'll be a little plastic gadget that you can slip your transducer in. We're going to aim one end of the yardstick there at the middle of that transducer, the other end of the yardstick at the fluidostatic axis, looking for the bubble to be level in the middle. If it's not, we're going to raise or lower that transducer holder on the pole until it's level. Okay, we see that? Because it does affect your numbers. Just like having your arm in the wrong position to a body when you take a blood pressure will affect your values. Okay? Everybody okay so far? Okay. Now, foundations. Preload and afterload. You're going to hear preload and afterload until you are sick of it. But you've got to understand it. Because when I tell you this will make or break you, I mean it. So we're going to do everything we can to make it make sense. If I'm talking about preload, what would the definition of preload be? Right here. But those are just words on a slide. We got to make them mean something to us. So who wants to put them in their words? What does preload mean to you? Don't be shy, or I'll call on you.
So, like the ability for the heart to stretch and how much fluid is inside.
Okay, very good. What were you going to say, Quan?
I was just going to say you can kind of be like the end diastolic volume.
Okay, so say that. I've got a 7th grade education level. What does that mean?
The amount of blood is in the heart at the end of diastole.
Okay, what's diastole?
When the heart is at rest.
Perfect. Okay, remember, you're going to be talking to people who will not have your education or training and will need layman's terms. Excellent, excellent. So in other words, there's 2 factors that are going to determine preload. This is important stuff, guys. One of them is the ability of that muscle to stretch. The muscle has to be able to stretch to accommodate volume. The other important factor there is volume is what's creating the stretch. Isn't it true that a balloon that has not been filled with air or fluid is not going to stretch? But isn't it also true that I need that balloon to have the ability to stretch to accommodate volume? Is a water bottle, water heater bottle, you know, y'all young. Back in my day, we had really, truly hot water bottles that you put in your bed when your back was hurting you, whatever. They were red, and they weren't a Mylar balloon. Is a Mylar balloon, does it have the ability to stretch past a certain point? Nope, that's it, right? Okay, so think of that as a heart muscle. Everything we're talking about in class, think of it as heart muscle. If the heart muscle has fibers consistent of that of a Mylar balloon, there's only going to be so much preload it's going to allow, isn't there? And isn't it true that if I have a patient that's volume depleted, they're not going to have a lot of preload? Isn't that true too? There's nothing to create the stretch, in other words. Are y'all okay? I'm going to ask that a lot too, and I want you to be honest if you're not. So preload is determined by the ability of those fibers to stretch and the volume that's going to create the stretch. Now there's another really important factor we'll talk about later, okay, and that's the ability of it to recoil. So we got preload under control so far? So let's do an application example. Jessica, your patient has come in with days of intractable nausea, vomiting, diarrhea. What do you think your preload is going to be? Increased, decreased, or untouched? You can phone a friend. Everybody's looking like, I ain't your friend today. I'm just joking.
Maybe decreased,
Okay, why?
because they're getting a lot of volume out with the diarrhea, the
That's
nausea.
right. We're losing vascular volume, aren't we? Because even though nausea, vomiting, diarrhea is not coming from the vascular space, it's going to pull from there, isn't it? Y'all see that? Okay. Peoria. You have a patient with renal failure. How do you think that's going to affect their preload? Is it going to increase it, decrease it, or unaffected? Not affected at all. Very good. Why is that? See that? Okay, these are application now. This is how you need to be thinking, okay? All right, let's move on to afterload. Afterload seems to be the one that gives people the most trouble. So, Tyler, in your words, what does afterload mean to you?
The amount of pressure that it has to push against.
Excellent. Did y'all hear that? Okay, when that heart contracts, it's going to meet resistance, isn't it? What we're measuring is how much resistance. That's what afterload is. How much resistance is this heart having to contract against to get volume out? What does it have to overcome? So, Jay, can you give me an example of what kind of patient might have a higher degree of afterload? In other words, a higher degree of vascular resistance.
Well, a patient the cardiac output, I would,
Y'all, I just want you to think.
hypervolemia.
Okay, hypervolemia, I'll take that. What else? Think of the vessels themselves. Atherosclerosis. Both are true. So you're asking yourself what kind of patient is going to have a problem with resistance? Whose body in the vascular space is going to increase resistance to this volume coming out? Both of those were great examples. If there's already a lot of volume there in the vascular space, isn't it going to be hard for the heart to forcibly contract fluid against it? If those vessels are rigid and hard, isn't it going to be hard for that heart muscle to contract against that? Okay? So we know we have the definitions, that's our knowledge. We understand how that works, it's our comprehension. And we just did some application. Okay? Because what are we going to do with preload and afterload in healthcare? They're almost all affected by pharmacology. And this is where our pharmacology comes into play. Okay? How are we treating preload and afterload? What do we need to do? This is just for your review of capillaries and how they stretch and all that good stuff. But while we're here, let's talk about it. I said a moment ago, it's very important that the heart muscle can relax during diastole to accommodate that volume. But it's also very important that it does what? Snap shut, back up, not shut completely, I'll get my point. That it can squeeze. A balloon that has been blown up entirely too many times, what happens to it eventually? Does it ever return to its original size? Because eventually those fibers become weak and they become overstretched. Now, a healthy heart can overcome temporary problems. It can overcome that with no long-term consequences, okay? But a sick heart who gets sick because it's dealt with this on a chronic basis will have long-term consequences. It will long-term affect the function of the heart. So when we're looking at the ability of that heart to stretch, we also need it to be able to get back to its original shape and size. Because that contractile force is what determines my cardiac output, along with afterload and preload. Okay? So that's just for you to remember how that works. So let's talk about CVP. You're going to hear CVP in Module A, in Module B, in Module C, in Module D, and F, and in Module E. So what does that mean?
Know it.
Yeah, that's right. By golly, you got to know it now. Okay? And it's really one of the more relatively simplistic ones to understand, because we're just going to think about, okay, where is it taking this number? So, and you do have to know your normals. You have to. Okay? Absolutely. You guys think about it. If you don't know what a normal blood pressure is, what good is it for you to take somebody's blood pressure? It's of no use, no purpose. If you don't know what a normal heart rate range is, what good is it for you to take somebody's heart rate? It means nothing. okay? So we gotta know our normals. CVP 2 to 6, what it's telling me, oh, she's got a picture, I love it. Can I borrow for a second? Look at, I just look at her. Okay, see, I'm visual. Love it. Okay, so she's got a picture of the heart. Those of you that are visual learners, you need to get you one. Because part of this PA catheter is it went through the heart, you know, the terminal end of it's sitting in the pulmonary artery, but remember I said there's little ports along the tubing? One of those ports sits in the right atrium. So Chelsea, tell me how, because we're going to do the comprehension. So CVP is going to tell me overall circulating volume. Okay, that's what that number is telling me, is how much circulating volume have we got on the body. How is it doing that in the right atrium? What happens in the right atrium? You can phone a friend if you want. And there's no big red buzzer over here going, if you're wrong, you're wrong. Move on. We're not even worried about it.
That's where the blood's pulling in from the venous cables.
And so where is that coming from? From the venous cable from where? From the,
Bottom.
there you go. Y'all hear? The way that it can tell me about overall circulating volume is because this number is derived from the right atrium. What happens in the right atrium is that's where volume gets returned to from the body. So therefore, if I've got this much volume in the right atrium, it had to come from where? The body. And that's how I can use that number. So what kind of patient would this be really helpful in? Doesn't even have to be a cardiac patient. Did I bring my word yet? What kind of patient would this be awesome number to have? Oh, no? Keep going. There's an indirect relationship there.
Renal? Oh, yeah.
Why renal?
Or like how much fluids in the body or how much.
Because what a renal patient's going to have what, a higher or a lower number? Higher until they've had their dialysis, correct? We remove that excess volume. What kind of patient's going to have a lower number? A patient that's in hypovolemic or hemorrhagic shock is going to have a lower number, aren't they? Now we're going to get to the septic. You're correct, but we're not going to tangle that today. Okay? See how that number is helpful to me as a provider? What about my patient with chronic heart failure, left-sided failure? Isn't this a really cool number to know? Like, oh man, if we got this much volume on the body, we need to be doing something about that before it becomes a problem. Okay? So you see where CVP is very useful. You see how we get it. The definition is right there. It just tells you what it is. That's knowledge, and along with the normal value. The comprehension of is how does it do that? Because it's in the right atrium. Volume returns from the body to the right atrium. What can I do with that number? That's the application. What can I do with this number? What is it going to tell me? How can I treat? Is this number going to be an indicator of preload? Yes or no?
Yes.
Okay, make a commitment. It's okay if you're wrong.
It is, isn't it?
Because if this much volume is returning to the heart, it's going to go to the pulmonary system, it's going to come back to the left atrium and into that left ventricle where I'm looking at preload. Y'all don't misunderstand me. Preload and afterload occurs everywhere in all four chambers, but we are concerned about the left ventricle. Okay? That's who we're talking about in terms of preload and afterload. Because that's our workhorse chamber, isn't it? That's the one responsible for getting it throughout the body, correct? Okay, so if I've got a really high CVP, it stands to reason I'm probably going to have a pretty high degree of preload, right? Okay. CVP, know your normal, be able to understand it. Pulmonary artery pressure, okay, so the very distal end of the pulmonary artery catheter sits in the pulmonary artery. And in that space, it is going to give me some numbers, a systolic and a diastolic, and you must know your normals. We're going to talk about, through this module and in Module B, some things that would increase or decrease my PA pressure. The ones that we'll talk about for this module, obviously, is going to be pericarditis tamponade. This we already understand. If you have a reduction of volume, you're going to have a reduction of pressure. So let's think about what do we do and what do we check in everyday life that demonstrates that direct relationship between volume and pressure? What do you have? What about your tires on your car? Isn't it true there's a direct relationship? The more tire volume, air you put into that tire, isn't it going to increase your tire pressure? And the lesser the volume in your tire, isn't it going to lower the pressure? There's a direct relationship. As volume increases, pressure increases within a space. Okay? So here within this vascular space, I would expect a higher PA pressure in situations where I would have one of two things happen. Either A, the volume has increased, or B, the size of the chamber has changed. So let's go to thinking about our tires again. Anybody here drive a Mini Coupe? Good. That scared me. Like, I learned how to drive in Dallas, Fort Worth, Texas, y'all. You're not gonna get on a Mini Coupe on Loop 820, okay? I'm just gonna tell you. Well, if you are, you brave. I had a big old Galaxy 500. We called it the Blue Moose. Get on Loop 820 with. Okay. Y'all have seen Mini Coupe tires, so you get my drift, right? And then you've seen these boys with the big boy trucks, haven't you? The louder, the bigger, the less fuel mileage they get, the better, correct? Clearly mom and dad paying for that, because, okay. Isn't it true that that Mini Cooper tire is not going to be able to accommodate the same volume as the big tire is? Okay, so isn't it true then, if we change the size of the vascular space, that that's going to affect pressure too, independently of the volume? Isn't it true? If I have a vasoconstrictor on board, what do you think it's going to do to your PA pressure? It's going to increase it. If I have a vasodilator on board, independent of changing the volume, what's that going to do to the pressure? It's going to reduce it, isn't it? Y'all see that relationship? So when we're looking at our PA pressures, we're looking at those two variables. Okay, is this volume affecting this number? Or is this the vessel itself affecting this number? And then we're going to talk about those different situations which would increase or decrease, but you get it now, don't you? If I've got a patient who is volume depleted, you're not going to have high PA pressures. There's not enough volume in that vascular space to create the pressure. Your tire's leaking. Okay? All right, everybody good? Okay. Now, because of where the terminal end of this catheter sits in that pulmonary artery as it's approaching that pulmonary bed, we can use it a lot to manage our left ventricular heart failure patients. So now I need you to think for just a second. Oh, Jay's got a picture too. Can I borrow Jay?
Yes, ma'am.
All right, so when you're looking at a heart, you guys, remember this, you guys, there's no way to possibly be able to understand abnormal if you don't get normal. You can't. You're going to mess up. You have to first understand normal to be able to understand abnormal. Okay? Under normal conditions, Chloe, the right side of the heart sends volume where? Under normal conditions. Where's it going to go to?
The right side part?
Uh-huh.
The left side.
Okay, so it's going to go through what specific place? From the right ventricle to what? To the pulmonary artery. It's going to go to the pulmonary bed, and then where's it going to return to the heart? Samantha? What chamber will receive that blood after it's been in the pulmonary bed? Look at your picture if you got to. It's okay. Phone a friend. Y'all don't answer her phone if she rings. Left atrium. Okay, guys, you go home. You go home. And you review this till it is like crystal clear in your brain. You got to know that. Because I'm going to tell you what's going to happen. You're going to mess up when it comes to that heart failure patient. You're not going to understand what's going on. Okay, so if I understand that blood flow starts at the right atrium, goes to the right ventricle, goes to the pulmonary artery, goes to the pulmonary bed, comes back to the left atrium, and then to the left ventricle. From the left ventricle, where does it go next? Aorta, and to the body. If the right ventricle fails, where's volume going to go instead of where it was supposed to? It's going to back up to the right atrium. From there, where's it going to go? To the body. If the left ventricle fails, where's it going to back up to? To the lungs. Okay, left is lungs, right is body when it comes to failure. Left is lungs, right is body. Really important that you understand that. And I'm telling you right now, if you don't, you're going to mess up on every question related to this concept. So let's make sure you really get it, you really understand where blood flow is supposed to be going and whatever. Because this pulmonary artery pressure right here can be very useful in managing that left-sided heart failure patient. Even though we've got a number that's better than this, but we don't use it today. We use this number. So in other words, if my pulmonary artery pressures are rising and I've got a patient with left ventricular failure, what can I be suspecting is going to happen? Go, you're thinking, I see it, Jessica. Go ahead and say it out loud. Don't be shy. It's going back up to the lungs, right? Isn't it going to be useful for me if I start seeing that PA pressure rising that I can go ahead and act on it now instead of waiting until my patient's in pulmonary edema? Like, hey, PA pressures are going up. What's going on with that? Okay? You see how we use that? Very helpful. Now, again, you've got to know your normals. I will talk about the different cardiac disorders in this Module A. The pulmonary ones we will pick up in Module B. I will not test you on things like a pneumothorax or a PE in Module A. Okay? This is the wedge pressure I was talking about a while ago. And I think my balloon's busted. I don't think it's going to work. In my day, RNs obtained wedge pressure. So what is a wedge pressure? Let's go back to, that's an okay picture, but I got a better one. I think. Okay. All right, so you saw the terminal end of the catheter was in the pulmonary artery. All right. If we were ordered to do wedge pressures, and they were usually Q4 hours, every 4 to 8 hours, they wanted you to wedge your balloon. So what that meant was this. We would inflate the balloon. I doubt it's going to do it because I think it's busted. Let's just see. Oh yeah, it's dead. Okay. There's a balloon here at the end, a very small balloon that you can only inject with air. There's a certain syringe that will come with your PA catheters. It's not, don't go get anybody's syringe. This one locks out at 1.5 mils. You can't pull back on it any further because that's the max volume you can put in this little balloon. You would inflate your balloon and it would float to the capillary bed. Because remember, air is lighter than volume, right? So with every cardiac cycle, it would float until it wedged in the pulmonary capillary bed. And I'll talk to you about how would I know that it did that. Okay, so the PA catheter would typically sit around here. I would inflate my balloon and it would float until it wedged in that pulmonary capillary bed. Now, again, even though we don't do these today, you have to understand what they measure because your physicians might do them, okay? And we had one not too long ago where the nurse asked me, can we wedge balloons? I said, not anymore, you can't. Your provider's going to have to do that. But looking at your monitor, you'll understand. I'll show you the waveforms, how they change. But you have to know what a wedge pressure is going to tell you. So we have to know our normals. What's your normal value up here? 8 to 12. You've got to know it. What that number is telling me very specifically is what volume do I have in that pulmonary capillary bed. So you see how this number was really, really helpful for a left ventricular failure patient? This was our go-to. What's our wedge pressure? This was our favorite, okay? It gives you some other ideas like you can see the relationship there with too much circulating volume on the body that's going backwards. Don't worry about the shunt. Mitral regurg we will talk about either today or what's today? Tuesday, Thursday. Okay? But you can understand now what we're talking about, right? If this left ventricle has failed, this is a pitiful picture. If the left ventricle's failed and volume backs up to the atrium, we know that from the atrium it's going to go to the pulmonary bed, isn't it? So if my PA pressures are rising and my wedge pressure's rising, I can be very strongly suspect that we've got too much volume backing up to the lungs. Okay? That's what a wedge pressure is going to tell you. But because of dangers associated with that, we don't do them anymore. There was a really serious complication, and it did occur, where this little balloon would get stuck in that pulmonary capillary bed. Now I want you to think about it, capillary bed. Are those things friable? What's friable mean? It's okay if you don't know, just tell me.
They're gone.
They're easily damaged and they easily bleed. So if I've got a balloon stuck there, and it only takes a few moments for those vessels to start to, what? To die. What's going to happen when they do? They're going to bleed. Do we have serious complications now? Yeah. We got bad problems on our hands, okay? So because those balloons tended to stick, and and we couldn't get them deflated or unstuck from where they were wedged, we don't do them anymore. The risks of the procedure no longer outweigh the benefits of the procedure no longer outweigh the risks associated with it. And so instead they're like, let's just stick to PA pressures, unless we absolutely have to have a wedge pressure. In that case, your provider will do it, okay? I'll show you how we would know that a balloon has been wedged shortly. SVR, you don't have to know this formula. The formula is here for you to understand how do we get it, okay? But you do have to understand what is it telling me. If you break down the words of it, systemic means it's where? Throughout the body. Vascular tells me what space I'm referring to. Resistance. So what I'm saying in layman's terms is how much resistance are in your vessels, right? A patient who has a high SVR would have what related to their afterload? How would a high SVR affect afterload? Think of what afterload is. Afterload is resistance to the volume getting out of the body. If there is a lot of resistance within the body, how is that going to affect the heart's ability to contract and get the blood out? It's going to make it harder for it. It's going to increase your afterload, isn't it? A high degree of SVR is going to increase your afterload. Brandy, I haven't called on you yet. Brandy, what pharmacological classification could reduce SVR? What pharmacological drug class can reduce vascular resistance? You know, think about it. Phone a friend. Okay, I want the big broad category, like the big one. Vasodilators. So what relationship then would a vasodilator have on your afterload? Will it increase it or decrease it? Decrease it. But we have to have a certain amount of SVR, guys, in order to keep volume circulating the way it's supposed to, and keep venous return intact, etc. And we'll talk about that when we get to our sepsis module. So we've got a normal value, 8 to 1200 dynes per centimeter to the -5, whatever, per second, whatever it is. We need to know our normals, and we need to understand things that could affect SVR, okay? And how that has a relationship to afterload. Stroke volume. You do need to know the stroke volume. Actually, I'm going to give you the cardiac output one. Don't worry about this volume. This formula, I want you to do the cardiac output when we get to it. Okay, so stroke volume. We're going to talk about 4 different ways we're measuring volume leaving the heart. Okay? We're going to talk about 4 different ways volume leaves the heart and how we, in terms of measurements. One of those measurements is stroke volume. Stroke volume is defined as the amount of volume per beat. How much volume is ejected per beat? You've got your normal values on there. It is important, again, I'm going to stress that, you've got to know normals. So how much volume do we need ejected per beat? We're going to do a little example on the board here in a minute. Whereas cardiac output is the amount per minute that's ejected. Don't worry about I don't even know why we have this on here, to be honest with you, the 5, you definitely not be tested on it. We don't do it like this anymore, but the state says it has to be there, so there it is, whatever. We don't do that anymore. Okay, those were my day when we did manual injectates. We had to draw up 10 cc's of sterile fluid, iced fluid. It was kept in this sounds so archaic. It was a styrofoam bucket that attached to our IV pole with cove transducer tubing that sat down inside it. We had ice on top of it and water. It had to be very, very cold, because as we did those ice cold injectates through that blue port of my PA catheter here, it would give me a number on my screen because it used thermodilution techniques, physics, to determine, in other words, how long did it take this ice cold water to get to a certain temperature within the heart. Sounds kind of spooky, isn't it? That we're injecting ice cold water to a heart, but we did. That's what the manual machines do today, only they don't have to use ice cold water anymore. So things like hypovolemia, that makes sense, doesn't it? If the amount of volume per minute is reduced, we understand that hypovolemia can play a role there, right? If the volume that came into the heart's low, then the volume that comes out of the heart's going to be low. Hypervolemia, I can understand how that could increase it. We'll talk about some of our other complications through the module, but in MI you had last semester, what does a heart attack do to heart muscle? It stuns it, okay? It's kind of like that person that you're looking at something, you're like, am I seeing what I think I see? Your heart muscle truly gets to this kinetic state where it's like, I think I want to contract, but I don't know if I can, okay? It's stunned myocardium. So during an MI, because it's not getting the oxygen it needs to the muscle fibers, it doesn't contract like it's supposed to. Long-term consequences from an MI, if there's a big area of scar tissue, it's not going to contract. Scar tissue doesn't respond to any nerve ending results, okay? Arrhythmias, so back to what you were saying earlier. If I have inadequate filling because I don't have a coordinated attempt between two chambers, isn't that going to affect my filling? Okay? And then what is the papillae muscle, y'all? What is it and where is it? Guess what you're going to do? You're going to go home and you're going to look at a picture of the heart. Very good. Papillae muscle, think of your papillae muscle as the hand on the kite. Okay, think of your valves as the kite, think of the chordae tendineae as the strings, and the papillae muscle as the handle. Okay? If your papillae muscles rupture, what happens to your strings of your kite? You just let go. There's no more function or coordinated effort there. Okay? Why would I see an increased cardiac output in hepatic disease? What happens with hepatic disease to volume? Increases, doesn't it? Say it, Jessica. I see you doing your thumbs up over there. Be proud. It increases. Okay? Know your normals. We're going to do an equation here in just a minute. Let's do it now. Just pause for just a second. I do need you to understand this. All right, so stroke volume, heart rate, cardiac output all have a relationship. What now?
I said that's OB on the board.
Yeah, we're not in an OB today. We're gonna get rid of that. Okay.
Yes.
Yeah. Okay. So I have some measures that are important with my determining what determines my cardiac output. Heart rate and stroke volume. Right? What was the normal stroke volume? Y'all remember?
60 to 100.
Now that's per beat, right? Cardiac output is measuring per minute, isn't it? So there's another part of this equation that's going to have to come into the factor to determine my cardiac output, and that is the heart rate, because heart rate is per minute, isn't it? Okay, so let's do an example. Let's say I've got a patient coming in who has been hemorrhaging or lost vascular volume fluid because of intractable vomiting, whatever. Okay, whatever. They've lost volume. And their stroke volume is down to 40 mils. Okay? What was a normal cardiac output? Look at your slides. 4 to 8 what? Liters per minute. Okay? We know this is our normal. We got to get from here to there. Okay? So if my stroke volume is 40, what does your body do? And I told you to look up sympathetic stimulation. Through sympathetic stimulation, when it detects a loss of volume, what happens? Heart rate increases, doesn't it? So maybe my patient's normally at 60 or 70 beats per minute, but now that the body's sensed this loss of volume, it's like, you know what, we're going to pitter-patter away at 100 instead. So if I were to take the 40 stroke volume, multiply it by the 100, I'm going to get what? Milliliters. If I convert that to liters, I have what? You see how it compensated? And we were able to achieve an adequate cardiac output because of the compensatory mechanisms that are in place. What if this patient, however, was on some serious beta blockers? And heart rate didn't do that. What's going to happen? And this is your cardiac output. You guys, you have to understand sympathetic and parasympathetic stimulation absolutely for this exam. and for every module that we go through. Especially when it comes to the pharmacology. Okay, so this is what, an example of how we can derive at that cardiac output using those two variables. If this was our situation, and I've got a patient's major beta blockers, which of the two can I fix, heart rate or volume? Volume. I can give volume, can't I? I can wide open that normal saline, that LR. If it's bleeding, they need blood, is what I'm going to give them. I got to look at which of these two variables can I affect pharmacologically. You can't undo a beta blocker. It has to wear itself out. But I can fix volume. Okay? Y'all okay so far? Okay. We're going to do a lot of different examples, so I want you to figure it out and work with it and understand what we're getting to, okay? So cardiac index is the third way that we're going to talk about in this class that we can measure volume leaving the heart. This time, it's considering body surface area. Body surface area. Isn't it true that a patient who has 80 kilogram body weight is going to need more than the person with a 40 kilogram body weight in terms of cardiac output? If you've got a little bitty yard to water versus a big yard to water, one's going to make your faucet work harder and your sprinkler work harder, correct? Okay. Isn't it nice to know that we have measurements that are very specific to my needs as an individualized person? So cardiac index takes that cardiac output, and all it factors into play with that is the BSA. Okay? That's all. But again, you must know your normals. Now there's a fourth way that I will talk about when we get to valvular alterations, but if you want to go ahead and put your little note there, you can put it, ejection fraction. Ejection fraction is a percentage of volume that leaves the heart. It's measured in percent, and 50% or greater is normal. But we will revisit that when we get to the valvular alterations, okay? Especially the dilated cardiomyopathies also. That's where it really matters. Okay? Mixed venous oxygen. Okay. What we're looking at here is you should have enough left over after uptake as a reserve. In other words, we shouldn't be using all of your oxygenated cells. There should be some still available. Okay, y'all remember when COVID first hit, and I blame the media. I will say it loud and proud. Toilet paper was extinct. I had to mail my daughter toilet paper in Mobile that my husband found in Troy. That was nonsense. And I blame retailers for not limiting. I do. I mean, they have some responsibility here. Okay? But clearly the supply did not meet the demand. There was no toilet paper left on the shelf. There was no oxygen cells left on the shelf for a reserve. So what this number tells us, if it's on the low side, is that why are we using more in this situation? What's going on? Why is there a greater demand than there is a supply? We should always have extra left over. There should always be toilet paper on the shelf. Okay? That's all we're going to talk about with this one. No, it's a supply demand. If it's very, very low, it's because we have too many cells uptaking extra oxygen, and we need to understand what's going on with that. Why are they doing that? All right. So my responsibilities for any type of hemodynamic assessment, and remember this includes arterial lines or hemodynamic assessments, okay, is that I know that the pressure bag is at 300. It has been, this transducer is zeroed and calibrated with the heart, and then I have an appropriate waveform on my monitor. So what have you been assessing in clinical all the way up through 202 that had a waveform on a monitor, even on the floor? Pulse ox, right? Now remember, when you're talking about oxygen saturation levels, it's not O2 stat. What happens when you tell a provider the O2 stat is at such and such? That's exactly what they might do, because what you're telling them in a matter of a moment is that you don't know what you're talking about. It's not O2 stat, it is O2 what? Stat. When I And do I say their O2 is at 70%? Are you talking about delivery or the level? Be specific. You can communicate two things to your provider, and they're erroneous. The oxygen sat level is at such and such, and they are on, even if it's room air, room air. Don't ever report one in the absence of the other, because that gives us a different clinical picture, okay? But when we're looking at our waveform here, I'm knowing that what I'm talking about, and I'm looking at a waveform. When you were on the floor working with that patient with their oxygen saturation monitor, and if that waveform was really, really dampened, were you really trusting the values that you saw? Not real comfortable that that's really legit, because it's not sensing appropriately. And likewise here, I should see certain distinct types of waveform on my monitor letting me know that this number is more reliable. So let me give you some better pictures in here. By the way, zero and calibrating at the fluidostatic axis only has to be done once a shift, unless your patient moves outside a 0 to 45-degree angle. So let's say when you assess them, you were at 30 degrees. Head of the bed was at 30 degrees. Later on the shift, you move it to 45 degrees. That's fine. You don't have to zero recalibrate. Let's say for whatever reason you dropped them to 0. You don't have to recalibrate. If I were to put them in Trendelenburg, if I were to go to 60 or 90 degrees, I have to recalibrate. Okay? Otherwise, it should only have to be done once on your shift. So what are we looking for in terms of characteristics on the monitor? When your physician's putting it, and we did so many bedside procedures, but we don't see them as often as we used to, but they still get done from time to time. We put a lot of these in at bedside, and your responsibility as a nurse is to, of course, monitor your patient's response to the procedure, knowing what the waveform is telling you, and being the other set of eyes for the provider who's looking at fluoro to determine where they need to go. So as the catheter entered the right atrium, we would have a real dampened waveform. As it entered the right ventricle, we would have a very distinct waveform. Do not confuse this with a rhythm. This is not a rhythm, okay? Not at all. And then as it went to the pulmonary artery where it was supposed to be, it would have a very specific pattern with what we call a dicrotic notch. Dicrotic notch. You do need to know that. D-I-C-H-R-O-T-I-C. Dicrotic notch. Forget the H. D-I-C-R-O-T-I-C. Dicrotic notch. That represents the functioning of the valves. That's what you're seeing there. When you see that little dip. Now remember I said, how would a nurse know that her balloon has wedged? I mean, I can't see inside the patient. I can't see that when I inflate that balloon, it wedged now, but I would see a change on my monitor. So my waveform would go from this pattern where it gave me a systolic and diastolic value to a dampened waveform where it would give me only one number. That's how I would know my balloon had wedged. I would deflate the balloon and wait until this pattern reemerged on my screen on my waveform. That's how I would know. I would record what this number was, and then go back to my business here. Remember, when you've got a PA waveform, you're going to have a systolic and diastolic value. So let's think clinical application for a second. Let's say you're taking care of a patient, and all of a sudden you look at your waveform and you see this pattern on your waveform. What is your priority? What is this telling me, first of all? That it's slipped back into the ventricle. That's what that's telling me. The tip of the catheter that's supposed to be sitting in the pulmonary artery has slipped back. See that top right picture? Has slipped back into the ventricle. What's my priority? Ask yourself this always. When you're at that point, you're like, oh, I don't know. Is there anything you as a nurse can do at this point? So that means you've got to contact the next level of care, which is who?
Doctor.
That's right. Because let me tell you, your ventricle doesn't like something bouncing around there. And what you're going to start seeing on your rhythm is ventricular ectopy. You're going to start seeing a lot of PVCs. Your ventricle's like, what are you doing down there? I don't want you playing in my ventricle. Pulmonary artery's like, whatever. The ventricle's not. So I see a RV waveform and I start seeing increasing ectopy on my monitor. Can I advance this catheter?
No.
Absolutely Absolutely not. Can medicine advance this catheter? Think before you speak. And then if you're having to question that in your brain, ask yourself this: can you advance a Foley catheter that's been partially pulled out? Yes or no? Okay, why not? Yes, you name it. Why can I not put a catheter back inside the human body that has slipped out partially? It's contaminated, that's right. So can a doctor advance this catheter once it's been pulled partly out? The answer is no. It has to come out. Okay? But you have to call and let them know what's going on. Okay? That's your responsibility to monitor that waveform and know what it should look like. Okay? Everybody okay so far? Okay. Each, like your CVP will have a very specific waveform. Go ahead.
Will we be responsible knowing those type of waveforms?
You're going to be responsible for understanding for sure what's going on here. Okay? I talked about this already. This is common sense stuff that we already talked about, and I just mentioned the arrhythmias part. Okay? Everything else on there we've already talked about. We're going to move into ALines, which is another form of hemodynamic monitoring. As we talked about in SIM orientation, this is real-time blood pressure assessment. It is invasive because it's in the vascular space. What artery sites do we use for A-line pressures? Radial and femoral. Okay? Now, guys, there's some care that goes along with that. It's in the arterial space. So do I want my patient going, ear, 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 ear? No. Do I want my patient going, yeah, no. No. Not today. That extremity has to stay straight. It cannot be bent. Now that does not mean I can't log roll a patient. They just vomited or whatever, with blood everywhere. I've got to clean them. I can log roll them, but I can't bend it. Okay? Can't bend this. So we stabilize the sites. Of the common sense stuff, you're looking for bleeding, hematoma, right? But since it's in an arterial space, what do I need to assess here? That's right. Is there a temperature change between the two extremities? What else do I need to assess? Cap refill. Sensation. Discoloration. Because remember, it's arterial, which means it's supposed to be feeding that distal extremity. It's supposed to be feeding that distal extremity. If we've got something that's interrupting flow there, we've got a problem, and it's a big one. Okay? People came in with the hand, they want to go back home with their hand. Okay? So we want to make sure we're monitoring distal perfusion. It should not obstruct distal perfusion. Am I going to be able to get a radial pulse here if I've got a radial A-line here? The answer is no. Okay? But what would I document to look for perfusion evidence, the temperature of the hand, the color of the hand, as consistent with the other, obviously, cap refill, etc. Is that part of my documentation for a patient with this line? Absolutely. We'll be looking for that, okay? That you looked at that. Has it been stabilized? If not, maybe I've got a patient who's not moving their extremities. Well, in that case, I don't need to stabilize it, okay? Again, there's going to be a waveform. Another thing I want you to make sure you understand, you guys. A pulmonary artery catheter, a intra-arterial line, is not an IV. What does the V stand for in IV? Venous. That means you're not putting anything inside this. In order for medicines to work, they have to circulate through what? The heart. Therefore, IV. They go intravenous, it's returned to the heart, it does its little gizmo and goes back out. If you're putting something in the arterial space, where's it going? Just to the end of the fingertips, the end of the toes, that's about it. It's not safe, and we don't do that. So please don't confuse that in the clinical setting. Make sure you really understand when you're saying things that you really understand what you're saying. So this is not going to be an infusion. This bag is not an infusion of anything. It's simply providing counter pressure in that arterial space. That's all it's doing. It's not infusing. Okay? It's not infusing, so don't refer to it as an infusion, because it's not. So in this arterial space, I know that I can draw from, but I can't put to. It will also have the pressure bag, maintaining that counter pressure force. It will also have a transducer, which also has to be leveled with the phlebostatic axis, because again, we're measuring pressures related to the heart, right? I'm monitoring that side, I already talked about for bleeding, all that good stuff, hematoma formation. And I can draw labs from this, even ABGs, because ABGs are arterial blood gases, so we can actually draw labs. You should be able to get your hands on at least one, hopefully sometime throughout this semester to get to do that, okay? We'll weigh some of the blood first because it's gonna be mixed with that, whatever is under pressure in the space, and then we'll use the second part for our draw, okay? The neat thing about it is it gives me a real-time pressure in a dynamic manner, meaning it's constantly there. You'll see it vary ever so slightly, and that's good. That's what I'm looking at real time. It has that characteristic dichrotic notch on the waveform again. So again, I'm looking at my waveform. Do I have that little notch? Yeah, remember that represents your valve function. Now this, guys, is not, this should be on zip hole. I just want to move it, I can't. But it looks like that. Okay, that's why I put that picture there. Okay? What kind of patient do you think an A-line would be very helpful for in managing? What kind of patient, when would an A-line be really beneficial to me? What kind of drug classification am I working with? I really want an A-line. Pressors, or the other end of it, vasodilators. So pharmacology that can either make it go up or down. And you're going to learn, we titrate drugs this semester. Everything, most of our drips are titrated looking for a specific response. Do you titrate? Do you have to call a physician every time you make changes? No, that's what titrating means. You'll be given parameters that tell you, I want the MAP to be X. And you're going to titrate that drip until you get the MAP to X. So before I give you a break, let's do our MAP calculation. This is another formula you need to know. So mean arterial pressure. We talked about this in SIM orientation. Well, that reads on there. Mean arterial pressure. You hear it referred to as your MAP. Some people call it MAP.
Just have one question.
Sure.
When you insert that, how far is it?
We don't, thank goodness. It's one of those kind of things like, yeah, you gotta do that. Medicine does that, or anesthesia. It's only about an inch long though.
Okay.
It looks like, when you take it out, now you can take it out, it looks like a glorified IV.
Okay.
Like, it's just in the arterial space. Now the femoral one's longer, it's bigger, it's a big boy. Okay? Good question though, but it just looks like an IV put in a different space. Okay? So mean arterial pressure, what do we want that to be? Anybody know?
65.
Good job, who said that, Quan? Quan, you've been listening to those lectures, haven't you? I am proud of you. No, I love it. This is stuff that makes me happy. Awesome. Greater than 65 millimeters of mercury. At, equal to, or greater than 65. I make my own symbol. Go and tell the math department. They don't need to know. I make my own note. Greater than or equal to 65. Dr. Kenny, do you have?
Sorry.
Oh, it's quite all right. I made it. All right, so how do we calculate an MAP? Here's your formula. Your diastolic times 2 plus the systolic, divide that number by 3. So let's do an example. Everybody got this up here so I can erase my little, everybody got this? Erase this? Okay. All right, so let's do a little example. Let's say your patient's blood pressure is 100 over, I don't know, 52. Looks like a good number to me. Okay? So we're going to take our diastolic times 2. Agreed? We're going to add our systolic. Okay? Y'all see? We had our diastolic times 2. We added our systolic. We got this number. And we're going to divide that number by what? Okay, so I have a 6, 19, 24, correct? So I have an MAP that is consistent, that tells me that I'm achieving adequate organ perfusion. That's what that MAP is telling us. Do we have adequate organ perfusion? Can't look at a systolic by myself and tell me that. So when you'll see that when we're dealing with our pressors, when we're dealing with a lot of our negative and positive inotropic drugs, when we're dealing with people in shock, we don't look at systolic. Systolic, I think I told you guys, I don't know, maybe a 202 orientation. I'm chronically hypotensive. I'm not on meds. I'm just chronically hypotensive. Every time somebody takes my blood pressure, they start to recheck. I'm like, just stop. That's what it was. I don't tell people I'm a nurse, by the way. That's my normal. But if you looked at my normal by standards of definition for normal, it's not normal, but it is for me. So what we need, but if you do my math, you'll see my MAP is greater than 65. So we look at that, like if we did let's do a patient with a blood pressure of 88/60. We're like, hey, dang, I don't like that. But let's just do the math and see where we're at. 120, 88, 802. And I already know if I've done this math, it was 68, that this is definitely going to be greater than 65, isn't it? And yet if I look at that number, I'm like, wigging out a little bit. But I'm like, no, there's no need to. We have adequate perfusion. Now guys, don't misunderstand this. If you've got a patient who's been clocking along at 150 systolic, we don't want to see this now. Okay? We're talking about when we're managing people on pressors. This is where we look at this number. Okay? So everybody got that formula down pat? Okay. The knowledge base of it is the formula, correct? That's the knowledge. The comprehension is how do we do it? Guess what you're going to do on your test?
Apply it.
That's right. Okay? All right, guys, if you want to take what time is it? Be back in here at 9:30. Take about 5 minutes to go tinkle, whatever you need to do. And we're going to start on valvular alterations, okay?